Hello and welcome to an HDRN Canada Pragmatic Trials training module. I'm Liam.
And I'm Angela. Today, we're talking about the art and science of subgroup analyses in pragmatic trials, and walking through judging their credibility using the sprint trial as our running example.
Yeah, we are going to cover a lot. We'll explain what subgroup analyses are and why they're important in pragmatic trials. Discuss estimands and estimators with respect to subgroup analyses, the caution needed when interpreting these results, and then walk through a step-by-step appraisal of a trial's subgroup results.
Subgroup analysis is one of those things that sounds straightforward, but in truth, it's easy to overinterpret noise and draw misleading conclusions. But let's not get ahead of ourselves.
So, starting with the basics. A subgroup analysis tests whether the treatment effect differs across categories of participants. Think sex, age group, or comorbidity status. The idea is to look for heterogeneity of treatment effect, meaning, does the intervention work differently for different groups of people? Subgroup analyses can help answer that, if they're done carefully.
When we shift from explanatory to pragmatic thinking, one of the biggest differences is who gets included. Explanatory trials usually have very specific eligibility criteria, perhaps patients who are younger, healthier, and easier to follow compared to the target population. Pragmatic trials intentionally include broad, diverse populations who look much more like the ones we might see in usual clinical practice.
And that's why subgroup thinking becomes so important. With this diversity, we expect more variation in how people respond to treatment. Subgroup analyses help us understand whether a treatment's effect is consistent across all those real-world groups. Or, alternatively, if certain characteristics, like comorbidity or setting, might change how well the intervention works in different groups of people.
Which brings us to estimands. Remember, the estimand defines what effect you're measuring and in which population. If you shift the focus to older participants, you're asking a different scientific question. And once you define that subgroup estimand, you need an estimator to operationalize it.
There are two main approaches: interaction models and stratified models. Interaction model, you include terms for the subgroup and its interaction with treatment. That lets you test effect modification formally while using the full sample. But there's a catch. Interaction tests are often underpowered. Keep in mind that almost all trials are powered for testing the main effect, not for detecting interactions or subgroup effects. The alternative approach is to fit separate models for each subgroup. This kind of approach is intuitive and doesn't assume a particular interaction form. However, splitting the sample into subgroup datasets means each subset has fewer events, which does two things. First, it increases false negatives. With fewer events per subgroup, standard errors get bigger, confidence intervals widen, and even a real difference won't clear the usual alpha of 0.05, or potentially a lower alpha if you are accounting for multiple testing. So, statistical power drops fast, and you are more likely not to see a treatment effect simply because the estimate is noisy. Second, it increases false positives. Every time we carve the data into another subgroup, we run another test. 10, 15, 20 tests. Even if nothing's going on, a few subgroups might look statistically significant purely by chance. So, whichever approach you choose, be transparent about its limitations and interpret the results with caution.
This brings us to the cardinal rule of pre-specifying subgroup analyses in your protocol and statistical analysis plan. And even with pre-specification, limit the number of subgroups you test. Doing analyses after seeing the data capitalizes on noise.
Here's the anchor for how we think about subgroup findings. Sun, Brielle, Walter, and Guyot asked a simple question. Is a subgroup effect believable? Their BMJ paper reframed the debate from a yes-no verdict to a credibility continuum from highly plausible to extremely unlikely. They reviewed common pitfalls, drew on prior guidance, and then updated the field with a clearer structure for judging subgroup claims. Importantly, they proposed a practical checklist organized around design, analysis, and context. That way, anyone can weigh the evidence systematically rather than chase isolated p-values.
Let's walk through the checklist for assessing the credibility of subgroup results, whether it's for your trial or from other studies. First, ask if the subgroup variable was a characteristic measured at baseline or after randomization. If it's a baseline characteristic, like age, sex, site, or comorbidity status, we preserve the balance created by randomization. If it's post-randomization, say adherence or a lab value influenced by treatment, bias can leak in, and any difference may reflect downstream effects of the intervention. The second question applies most to systematic reviews. Is the effect suggested by comparisons within rather than between studies? We trust within trial contrasts because participants were randomized and assessed under a single protocol. In contrast, cross-trial comparisons can mix apples and oranges, meaning there could be differences in eligibility, co-interventions, follow-up, and outcome definitions. The third item is whether the hypothesis was specified a priori. Credibility rises when the subgroup and its rationale appear in the protocol or statistical analysis plan before data lock. If it surfaced after peeking at results, treat it as exploratory. The fourth question asks, was the direction of the subgroup effect specified a priori? It's stronger to say who you expect to benefit and why beforehand. Older adults will benefit more due to X mechanism is far more credible than we'll explore age and see what happens. The final question under the design component asks, was the subgroup effect one of a small number of hypothesized effects tested? That is, keep the list of potential subgroup analyses short and justified. Every extra subgroup is another spin of the roulette wheel for an inflated type 1 error that might falsely claim a statistically significant result.
From an analysis perspective, we first ask whether the observed difference is more than random noise. Use a single pooled model with a treatment time subgroup interaction in your regression model. Then, report the interaction estimate and its p-value and the subgroup-specific effects with confidence intervals. Avoid judging by separate within-group p-values because that could be misleading. Always remember that interaction tests are often underpowered, so interpret a non-significant result as inconclusive, not proof of no effect. Next, probe whether the signal survives adjustment for other variables that could explain it. Things like baseline risks. If the interaction attenuates materially or flips with reasonable adjustments, treat it as non-independent and downgrade credibility.
For context, start by asking whether the magnitude of the subgroup effect is large enough to matter clinically. Keep in mind that small, borderline effects with wide confidence intervals are fragile, meaning a small number of outcome status changes are needed to move a statistically significant result to non-significant. Next, consider replication. Is the pattern consistent across studies, preferably shown via meta-analyses that pool within-trial interaction estimates rather than study-level averages? Consistency across different trials and settings boosts credibility. Inconsistency should cool enthusiasm. Then, look for coherence within the study. Does the subgroup signal align across closely related outcomes, for example, primary events and hospitalizations? Or do secondary endpoints point the other way? Finally, weigh biological plausibility against the pre-specified mechanism articulated in the study protocol. When magnitude, replication, coherence, and mechanism line up, credibility climbs. When they don't, treat the finding as hypothesis generating. So, with that foundation in place, let's turn to a case study for assessing the credibility of subgroup analyses.
The SPRINT trial was a multi-center, randomized controlled trial comparing reamed versus unreamed nails in patients with tibial fractures. More than 1,300 patients were randomized, and the primary outcome was the need for reoperation within 1 year. A key question asked whether effects for reamed versus unreamed nails differed for subgroups with open versus closed fractures. The trial's results showed that closed fractures favored reamed nails with a relative risk of 0.67 and a 95% confidence interval of 0.47 to 0.96, while the subgroup with open fractures suggested possible harm, a relative risk of 1.27 and 95% confidence interval of 0.91 to 1.78, a striking qualitative interaction.
But before we jump to conclusions about this subgroup effect, let's apply the credibility criteria. On the design elements, we first ask when the subgroup was defined, because randomization only protects baseline factors. For the SPRINT trial, the subgroup analysis of fracture type and smoking was measured at baseline. Next, the team used a pooled regression model with a treatment times fracture type interaction under one protocol, follow-up, and outcome set. This subgroup, along with several others, was pre-specified a priori in the study protocol and statistical analysis plan. However, the direction of effect was not explicitly pre-specified for open versus closed subgroups. The trial conducted nearly a half-dozen subgroup analyses, still enough to raise multiplicity concerns.
For question 6, we ask whether the interaction test suggests the subgroup results are unlikely due to chance, and consider interpreting p-values on a continuum rather than a hard cutoff. In the SPRINT trial, the p-value for the treatment and fracture type interaction was approximately 0.01 in the primary model, and it was attenuated to approximately 0.02 after adjustment. This is a modest signal, although not decisive, especially with several pre-specified subgroups. So, based on these results, we can presume partial independence with possible residual confounding.
Questions 8 and 9 ask whether the effect measure is large and consistent across studies. The interaction test yielded a qualitative interaction with relative risks of 0.67 for those with closed fractures, favoring reamed nails. In those with an open fracture, the relative risk was 1.27, indicating potential for harm. The effect measures are sizable and potentially practice-relevant if true, though large differences can still arise by chance. For question 9, prior meta-analyses by the co-authors hinted that reamed nails may be better for closed fractures, but evidence for open fractures was weak and inconsistent.
Questions 10 and 11 ask whether the interaction is consistent across closely related outcomes within the study, and whether there is indirect biological support for the hypothesized interaction. For question 10, we can look for the same subgroup pattern on outcomes that track the same underlying construct. In SPRINT, the qualitative direction did not translate into persuasive interaction tests for patient-reported outcomes using short-form surveys and health utility indices. That lack of parallelism across closely related outcomes weakens coherence and therefore lowers credibility. For question 11, we can ask whether a plausible mechanism supports the hypothesized interaction. Here, reaming enlarges the canal and improves the nail-bone contact, which increases stability, but it also disrupts the endostele blood supply and raises intramedullary pressure. In open fractures, where soft tissue and perfusion are already compromised, preserving blood flow with an unreamed nail is biologically appealing. This mechanism offers indirect support for the observed pattern, while still requiring caution, because the mechanism alone is not confirmatory.
On balance, the SPRINT subgroup findings are moderately credible. Variables were measured at baseline, and hypotheses were pre-specified. The analysis was within study, but the statistical significance is marginal and inconsistent across outcomes. The biological rationale is compelling, yet the effect size could be due to chance. Treat these results as hypothesis-generating rather than definitive.
The last few slides had a lot to take in, but that's the point. Assessing subgroup analyses requires a systematic checklist, not just looking at p-values. The key learning point here is to distinguish between hypothesis-generating and confirmatory subgroup findings. Hypothesis-generating results suggest new research questions and need replication. Confirmatory results come from pre-specified analyses with adequate power and can inform practice. And there's also a difference between clinically interesting and clinically actionable differences. A statistically significant result might not translate into meaningful changes in care if the effect size is small or inconsistent.
So, let's wrap up. 1. Define subgroup variables a priori and explain why each matters clinically or mechanistically. 2. Clearly define the population, treatment, outcome, summary measure, and intercurrent event strategy for each subgroup question. 3. Use pooled interaction models and always report point estimates with confidence intervals. Keep in mind that interaction tests have low statistical power, but testing many subgroups can inflate type 1 error rates. So, adjust or acknowledge for multiple testing. 4. Before concluding the existence of a subgroup effect, apply design, analysis, and context credibility checks. Finally, document definitions, modeling choices, and sensitivity analyses, and avoid selective emphasis.
Well said. Subgroup analysis is like a loaded tool. It can help personalize care or blow up your trial's credibility if misused. Thanks for joining us.